See my screen now.
Yes.
Okay, so today we'll continue from Corynebacterium diphtheria. So this is one of those gram-positive rubs that we talked about, alongside with diphtheria. We talked about bacillus. We talked about Corynebacterium. So those are the gram-positive aerobic rods that we talked about. So this is the last. This is the second to the last rather. We talked about bacillus. This is the second one, which is Corynebacterium. So it's a gram-positive rod that is arranged in angular format. So that's how you see it when they do the gram stain. And it's typical, it's a respiratory tract infection majorly. So it's transmitted through respiratory droplet. We are already aware of the way it causes its infection when it releases its exotoxin, which is the diphtheria toxin. Once it releases that toxin, what does it do? It inactivates elongation factor 2 by causing ADP ribosylation. So there are two organisms that are notorious for doing this. The second one is our Pseudomonas aeruginosa. So both of them, they inhibit protein synthesis by causing ADP ribosylation of elongation factor 2 so that you can inhibit the process of protein synthesis. When that happens, you are going to prevent production of protein at the pharynx. So the pharynx mucosa becomes, slowed off, they become necrotic. The person can develop pharyngitis with pus. So um yeah, so and we also talked about the fact that you can have dissemination of those toxins to so before I leave that place, when there is damage to the pharyngeal mucosa, there is purulent discharge from the pharynx, there's inflammation. Of course, the inflammation is due to the recruitment of the inflammatory cells, like the neutrophils, the macrophages, the lymphocytes, and everybody they come around and they form the pseudomembrane. So that's one of those characteristic features that we see in people with Corynebacterium diphtheria. So there's enlargement of the nearby lymphatic tissue and lymph nodes because of those inflammatory response, causing the bull neck appearance, and there's formation of the pseudomembranes within the inflammatory areas affecting the pharynx. It can disseminate to other organs, particularly the heart and the CNS. So when it disseminates into the bloodstream and find its way to the heart muscle, it can cause myocarditis by causing necrosis of the muscles of the heart. At the same time, it can also affect the nerves by causing necrosis of the nervous tissue because it impairs the protein that are important in the formation of uh, the nervous structure. So they can have peripheral neuropathy, they can have other nervous presentation. So when you are seeing somebody that's having sore throat, you are checking the throat, you are seeing pseudomembranes. The person is also presenting with chest pain, fever, tachycardia, suspecting myocarditis, and signs and symptoms of nerve involvement like peripheral neuropathy. You are suspecting Corynebacterium diphtheria. So we've talked about how this dissemination can cause myocarditis, which can lead to arrhythmias and also affectation of nerve causing neuropathy. So how do you diagnose them? We talked about the fact that you can gram stain them, and what do you see? You are going to see gram positive rods that are arranged in an angular form. You can also culture them in some of those agar that we talked about, like the 16 tellurite agar, where you are going to see the black colonies, and you can also um, um, okay, yeah, yeah. So the culture is essentially the satellite agar. You can also grow them in the low medium. So when you grow them in the low medium, you are going to see the club shape, which is when we're talking about the homorogun stuff. So you see the club shape colonies, which contains metachromatic granules. So we call them metachromatic granules because they can appear in different color, like blue and red. So anything that is metachromatic has different colors. So, but the typical color that you see for the Corynebacterium is the blue or the red granules. So you see the blue and red granules together within that low flare medium. So you want to remember the two mediums where you grow your Corynebacterium diphtheria. Number one, the 16 tellurite agar that you see black colonies, then the low flare medium. So what do you see on the low flare medium? You see club shaped cells that contains that are actually due to the fact that they appear like metachromatic granules. So those metachromatic granules look like club shape. They are club shaped. So that's that about um the Loeffler medium. Then there's something we call the Helix test. So Helix test is just a test for the toxin. This is the toxin that the Corynebacterium diphtheria releases. So that's it. So that's the test that I use to detect that toxin. We don't really need to, know about the process. We should just remember the name. So headache test for detection of the toxin for Corynebacterium, the true growth medium, the Loeffler medium where we are going to see cells that look like club, which are metachromatic granules from that bacteria. Then the other one is the thyroid agar where we are going to see black colonies. So how do we treat diphtheria? We can give the antitoxin to neutralize those toxins. So just like we are treating tetanus, so give antitoxin to neutralize those toxins so that you can suppress the damage they are causing. But you have only neutralized the toxin. You have not taken care of the bacteria. So you have to give antibiotics to take care of the bacteria. And what's antibiotic of choice? Erythromycin or penicillin is what we use. So you can give erythromycin to kill, or penicillin to kill the bacteria. And of course, the bacterial infection will have released some toxin before. So you want to give antitoxin to neutralize those toxins. You can also give them vaccine if they have not been vaccinated in order to prevent further future infection. So the vaccine that we give is also part of the pentavalent vaccine, the DPT vaccine. So D part is the diphtheria, the P is the pertussis, the T is the tetanus. So it's a toxoid because you guys know that it's releasing an exotoxin. So exotoxin, if you inactivate them, you are going to produce toxoid, just like tetanus. And if you give an individual that toxoid, you are going to have generation of antibodies against it. So the antibodies is what we call the antitoxin. So they are there so that when the infection is reintroduced again, we have the antibodies that are standby to neutralize the toxin and prevent infection. Okay, so the last for the gram positive rod that aerobic is the listeria. So listeria monocytogenes is the one we are looking at. It has many strain, many listeria organisms, but the one that is predominant is the listeria monocytogen. So it's basically um, free living in the environment in soil. It's ubiquitous in the soil. It's just there on its own. It's gram positive, just like you said, and it's facultative intracellular rod. So it can grow within the cells, particularly the macrophage, and it can also survive outside the macrophage. That's why we call it facultative intracellular. How do we get listeria? You can get it by consumption of unpasteurized dairy product. And forget about this deli meat. It just means stored like meat, just normal meat. So meat, dairy products, transplant center, and during delivery. So you can get it by eating dairy product. There are so many organisms that you can get through this dairy thing. So in addition to listeria, someone can also get brucella from it. Can get campylobacter. There are so many things, but we should just familiarize ourselves with those organisms that can be transmitted through that route. Listeria monocytogenes is one of them. So someone that is consuming unpasteurized milk, cold meat, or during childbirth, it can be transmitted, from the vagina into the baby, or it can even occur in utero by passing across the placenta from the mother to the baby. So because of the fact that you can get it through cold meat, it's actually due to the fact that it likes cold region, cold environment. That's where it can grow and survive. So when we want to culture it, sometimes we want to use a cold enrichment culture or medium to grow it. So if you refrigerate your meat, there's tendency of listeria growing on that meat because they like cold region. So that's why they call them that temperature cold enrichment. Cold temperature, cold medium, cold enrichment medium. We should not forget that. So 14th, dairy products that are unpasteurized, particularly milk, um, cold stored meat, transplacenta, and during childbirth. So what about this listeria? So once listeria get into the blood, they are being captured by the macrophage. Macrophage are phagocytes. So the next thing the macrophage will do is to form phagocytes. So phagocytes are just like a portion of the plasma membrane of the phagocyte. So they kind of form a bleb from their cell membrane to engulf that listeria. So they form a phagosome that engulfs that listeria, and the next thing they want to do is to fuse that phagosome with the lysosome so that they can digest them. But this listeria is very, very smart, and it's well adapted towards that mechanism. So it contains some virulent factor that can help it survive those phagosomal fusion and digestion. So number one, it has actin on its cell membrane. So whenever it gets into those phagocytes, it can polymerize the actin so that it can form like rocket tails that allows it to move. So we can see this red stuff that is in this image. Can we appreciate this red stuff in this
Yeah.
image? Yeah, so that
Yeah.
those are the rocket tails that are formed by the actin polymerization. So those actin polymerization just substitute for flagella that can allow it to move intracellularly. So it can move within the cells or across the cell. So it can move within the phagocyte or even outside the phagocyte into another cell through those rocket tails. So once they get phagocytosed within the phagosome, and you want to the macrophage wants to fuse the phagosome with the lysosome, what the steroid will do is just release a virulent factor that we call listerolysine. So listerolysine is from listeria, and what it does is just to make pores within the the phagosomes so that it can escape the phagosome and get to the cytoplasm. So when it gets to the cytoplasm, it already has the rocket tails, so it can move intracellularly, that is within the cytosol with the actin filament. Then it can also move across the cell membrane, moving out of the cell to other cells. So that is why listeria can affect so many organs. It can get to the brain, it can get to the amniotic fluid, it can get to the placenta, it can get to so many places through that movement action. So, do you guys understand the way it escaped that phagosome now? So it formed pores within phagosome through the listerolysine. So once it escaped the phagocytic cells, that is the macrophages, it can go to other cells. It can go to the brain cells. It can go to the other tissues of the body because of the fact that it has these rocket tails that can allow it to move. So what are the areas that listeria is predominant in terms of its affectation? It typically affects the placenta, so it can affect the chorion and the amniotic cavity, causing chorioamnitis. So it can cause chorioamnitis due to affectation of the amniotic cavity, the amnion, which is the covering of the amniotic cavity. It can, cause spontaneous abortion from there. So if there's chorioamnitis, the patient can also be there with fever, can be there with abdominal pain, a low abdominal pain. They can have prolonged or premature rupture of membrane. So once you are seeing that in the history, most likely they are trying to ask about Listeria monocytogenes. So it can cause chorioamnitis. And of course, if someone has chorioamnitis at a very early gestation, they can develop spontaneous abortion, when it affects the fetus. And from there, it can disseminate into the blood and cause septicemia. So that's the way to remember these three things. So chorioamnitis first. When there's chorioamnitis, it can affect the fetus, leading to spontaneous abortion. Then it can disseminate into the blood, leading to septicemia. Another thing it can affect again are immunocompromised people, the neonates, and elderly people. So one thing that is common to these guys is that they have weakened immunity. So the neonate, the elderly, as well as the immunocompromised. So it can cause meningitis in them. So Listeria is one of those organisms that can cause meningitis in people that are immunocompromised. We talked about the other ones. We talked about group A, and we talked about group B Streptococcus causing meningitis in neonates. We mentioned it. Causing sepsis also in neonates. Listeria can also cause meningitis in people that are immunosuppressed, particularly the elderly, the neonates, or the immunocompromised, maybe from people that have immunodeficiency syndromes or people that have infection like HIV or organ transplant. So any cause of immunosuppression, they can have meningitis. And in elderly people, what it just causes normal gastroenteritis that is self-limited. So they can have diarrhea, vomiting for a while. It subsides on its own without any need for treatment in healthy people that takes unpasteurized meat or takes cold meat that are infected with listeria. If you are healthy, you might not develop meningitis, but they can have acute gastroenteritis that are resolved on its own. Do you remember the um the, another organism that we mentioned that can cause a self-limiting diarrhea that doesn't go beyond like 24 hours? Do you remember? Anybody?
Not serious.
Uh,
Heated.
not really serious. There's something about
Or
serious. That one is
Eat
about
uh,
rice,
stable.
reheated
Eat
rice.
stable.
heated rice.
Yeah,
Yes.
it's
Is it
stable.
staff or is
No,
it
no,
staff?
no, 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 no.
You have
No, what we said about staph is that that one is rapid onset. Within like
Mhm.
1 to 5 hours, once you heat it, you are coming down with diarrhea. We said it.
So,
That is Clostridium paphyringes. Clostridium paphyringes. That's what we said.
so it will cause diarrhea. Then it will also now cause gas. This thing
Yeah,
in wound.
yeah.
Okay.
Many
Okay.
people,
Okay.
many people don't know that Clostridium paphyringes cause diarrhea. Most
Yeah,
people don't know.
resolving in 24 hours. That's true.
So
Yes.
resolve
Yes.
in
Yes.
25 hours. We should not forget that. We should not forget that. Yeah. So, in addition to causing that gastroenteritis in elderly people, it can cause meningitis in immunosuppressed. Then the last thing I want us to remember is that it can cause granulomatosis infarct. So granulomatosis infarct is a form of like a rash, a nodular rash that occurs in neonate, in babies, because of listeria infection. So there can be a granulomatous response to that listeria within the skin that can lead to development of that rash. So you should watch out for that. So if they are painting scenario of everything that is looking like listeria and you are seeing rash, you already know what they are talking about, granulomatosis infarct. So what's the treatment for listeria? Just give them ampicillin. Ampicillin. Another infection that I use ampicillin to treat is what? Your group B streptococcus. The mothers, once you have screened them at 35 to 37, you can give them ampicillin or penicillin. Hmm? The treatment for our Corynebacterium dystvariae is what? Erythromycin or penicillin. They give them the toxin to neutralize, the antitoxin to neutralize the toxin. Then after that, you want to vaccinate them to prevent them from next infection. So that's that about listeria. It's not more than that. They cannot ask beyond this. Once you are able to master this, you are home and dry with regards to listeria. Okay, so let's talk about the sorry guys, let me plug my phone. The uh the filamentous organisms. So the filamentous organisms include nocardia and actinomyces. They have a lot of differences. A lot of differences. Number one is aerobic, the other one is anaerobic. Nocardia is aerobic, actinomyces is anaerobic. Nocardia is partially acid fast, while the actinomyces is not acid fast at all. So we can already see nocardia, the image A, showing that purple coloration in a blue background. So that is how an acid fast organism will look like, just like the image we saw for TB during the early part of this lecture. Purple organism in a blue background. So acid fast, that's the way you see the xenestin stain. This is the way it appears. So it is partially acid fast, while actinomyces is not acid fast at all. Nocardia is aerobic, actinomyces is anaerobic. Nocardia is found in soil. So typically, that's where it comes from, the soil. It's just free living in the soil. Actinomyces colonizes the oral cavity. See, one thing I just want you guys to always remember when you hear actinomyces is the fact that it's present in the mouth. It is very important. All our dental students, they don't joke with this organism. If you ask any dentistry guy about actinomyces, they can go to town telling you a lot about it because it can colonize the dental plaques. They are just they can colonize dental abscess within the oral cavity. So they are even part of normal flora in the mouth. So they just wait for a needles that can assist in their proliferation and their pathogenicity to happen before they cause infection. So if somebody now start having a dental procedure that is causing injury to the mouth, forming necrotic debris, so they can thrive on those necrotic debris and cause infection. So we'll get there. Let's just talk about the nocardia first. Nocardia is aerobic, It is partially acid fast. It is found in the soil. It is found in the soil. So how does nocardia get into the body? You have to inhale it. So you have to inhale those nocardial microbes from the soil. So they can get aerosolized and get inhaled into the lungs. So it typically causes pulmonary infection. And the pulmonary infection that nocardia cause, it's basically essentially the same like tuberculosis. So, but it doesn't get worse like tuberculosis that they will now start presenting with hemoptysis. It's just a normal, cough, the um the dyspnea, the chest pain, and all those things that they have. So it might not get worse and be shared with hemoptysis, but cough, dyspnea, chest pain, those things they can be present there. So if you are trying, if because it can be chronic, it can cause a chronic infection. If it's now looking like TB, you're having this cough for more than 2 weeks and you are suspecting TB, if you do some of those TB tests, it will be negative, particularly the PPD. So PPD test is this PPD is known as the purified protein derivative. So it's like a tuberculosis antigen. So once you inoculate it into the skin, anybody that had a previous tuberculosis infection, they will have a reaction to it because the previous tuberculosis infection will have led to production of memory T cells. And you guys remember that tuberculosis is a type of what hypersensitivity is tuberculosis? Let me even ask you guys. You guys are going for exam, so you must have read it somewhere. You guys have read immunology on your own too. So what
Type 4.
type 4, fantastic. So type 4 hypersensitivity reaction that is typically involving the T cells. So the memory T cells are already there. So if you are introducing a new tuberculosis antigen, the memory cells are there, they can respond to that antigen almost immediately or within like 48, 24 to 48 hours, and you are going to see reaction, you know, within that area. So you can say that the PPD test is positive. But someone that has nocardiosis that is presenting with symptoms that is resembling tuberculosis, if you do the PPD, it is negative because nocardia is not tuberculosis. So that's one way you can use to differentiate them. And another thing about this nocardia, aside causing pulmonary infection, is that they can um they can be um inoculated into a wound within the skin. So if somebody has a wound or injury in the skin and it gets contact with the soil that contains the nocardial organism, the nocardia can get introduced into that wound and it can cause infection. So it can cause very serious skin infection like cellulitis. Sometimes it can cause subcutaneous abscess. So it can be bad. So you have to be you have to establish the fact that um, skin infection follows a damage to the skin already, maybe from trauma or injury. There is already an opening in the skin before it can enter. So you don't even need to be immunocompromised before you can get those cutaneous infections. The pulmonary infection typically occurs in people that are immunosuppressed. I forgot to mention that. Please don't forget. People that typically immunosuppressed, those are the ones that, because of course, just imagine something's ubiquitous in the soil, it's just there. And all you just need to get it is just to inhale it. So that means that everybody in one way or the other will have inhaled nocardia, and that means that everybody should develop that infection, but we don't because of the fact that you have to be seriously immunocompromised before you can develop pulmonary nocardiosis. So the cutaneous form, you have to have a breach in the skin, get inoculated into it. It can cause cellulitis, it can cause subcutaneous abscess in very serious condition, and when it gets disseminated into the blood, it can travel to the brain and cause a ring enhancing lesion like cerebral abscess. So the person will just present with some focal lateralizing sign like seizure and all those things. So not be able to move one side of the body and from the abscess and you know all those things. So those are coming from the cerebral abscess in response to the dissemination of the organisms to the brain. So we should not forget that three things: the pulmonary system, the skin, and the CNS. No cardiosis. CNS, skin, pulmonary. CNS, skin, pulmonary. Very easy. No cardia. So how do you treat it? You just give them Septrin, trimethoprim, sulfamethoxazole. Trimethoprim, sulfamethoxazole is a treatment for nocardiosis. So the actinomyces, they are anaerobic, they are not acid fast at all. They are normal commensals of the oral cavity, the reproductive tract, as well as the gastrourinary tract, the genitourinary tract, sorry, the genitourinary tract, the reproductive tract, as well as the oral cavity. So you can find them within the uh, the urethra and all those things. You can find them within the vagina, reproductive tract, and you can find them in the mouth. But particularly in 70% of the cases, they are notorious for causing cervical oral or cervical facial abscesses. So the most common form of infection from actinomyces is actually the one that affect the face and the neck, the face, like the head generally, cervical facial. So when somebody um undergoes like a procedure, let's say um maybe a dental extraction, and there's injury to the teeth, you know, with time there will be necrosis within that area. The tissues there will become devitalized. These actinomyces already there can start growing on those tissues. They start proliferating and they start causing chronic inflammatory response in that area. So the chronic inflammatory response, gets so severe that it can lead to formation of sinuses. So sinuses are just like discharging tracts, sinus tract that connect to the external surface of the skin from the mouth. They connect to the external surface of the skin and they discharge some granules that are yellow in color. So we call them sulfur granules because sulfur is yellow. So those granules are yellowish in color. We call them sulfur granules. So once you see an individual having like a granulomatous disease affecting the face, with fibrosis everywhere and presence of sinus tract, that is nocardia. And these sinus tract are discharging yellowish materials. Those are the sulfur granules from actinomyces. That is it. So it's very common in people with dental caries or people that have, okay, yeah, it was even mentioned, dental extraction or any trauma to the face. Someone that has suffered maxillofacial trauma, there'll be necrotic tissue in the face. So those are needles for those actinomyces to start growing. They become pathogenic and you have inflammatory cells coming in response to those organisms, causing chronic inflammatory damage to the face. And at the end of the day, you establish that those sinus connections from that side of inflammation to the external surface of the skin, where you can see those granules discharging. It can also affect the abdomen. It's just good for you guys to know it. So it can affect the abdomen, so they can have diarrhea, abdominal pain, and you can also see those discharging sinuses in the abdomen. Then last part that they affect is the pelvis. So they can affect the pelvis, they can form pelvic abscesses, and also they can cause pelvic inflammatory disease, particularly in people that use intrauterine devices. So the reason is not actually well known, but epidemiologically, it has been discovered that people that use IUD rather, they can develop pelvic inflammatory disease, which is caused by actinomyces. The major organisms that cause PID, do we know the organisms that are typically implicated in PID? We've done it in repro. I think we did it like
Is it not chlamydia?
chlamydia and what?
Is it not chlamydia?
Neisseria.
Yes. So chlamydia and Neisseria, those
And
are the two common organisms. So you see somebody present with fever, fast swelling, vaginal discharge, abdominal pain, you are thinking of PID. You are thinking of PID. The next thing the question will ask you, what is the likely complication from this? So what are the complications we can think of from PID? Anybody? Someone has a PID. What are you scared of? So you guys remember that PID is like a complex.
Tubo-ovarian abscess.
tuberculosis.
TOA.
The what?
Tubo-ovarian. Okay, is that like a complex?
Yeah. So tuberculosis abscess is part of PID. Yes. It's part of PID, but
Okay, it's part of it.
it's not like a. You get what I'm saying? Yeah. So it's not.
Salpingitis, uveitis,
Yeah.
endometritis.
It's just like you telling us PID again. So what will those guys now cause? So they can cause infertility. Yes, they can cause infertility.
Additions.
They can
Okay.
cause
That's what you
addition.
wanted. Okay.
Yes, I will agree with that. They can cause addition. They can cause infertility. They can cause ectopic pregnancy.
Ectopic pregnancy.
Yes, they can cause peritonitis. The tubo-ovarian abscess can rupture
Yeah.
and they can disseminate
Peritonitis.
into
Yeah.
peritonitis. So how do you treat the nocardia? Give them penicillin. So the code is SNAP. The code is SNAP. 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 So your Septrin for your nocardia, your penicillin for your actinomyces. SNAP. So you guys should not forget. You guys should not forget someone that had undergone treatment in the oral cavity like extraction or suffered oropharyngeal, oral maxillar um, trauma, trauma to the face. Necrotic tissue is in both of them. You know, the actinomyces can multiply, they become pathogenic instead of being normal commensal now. So they become pathogenic, chronic inflammatory response, fibrosis everywhere, formation of those discharging tracts that release sulfur like ground. So you should not forget that actinomyces comes to mind. Someone that is using IUD that develops PID, you are thinking of actinomyces. Okay, so we'll be moving to mycobacterium. So mycobacterium, we know mycobacterium very well. It has so many variants. Yeah, mycobacterium tuberculosis, mycobacterium avium intracellulare complex, um, scrofulaxium, and marinum. So there are a lot. There are even more than this. So I'm happy that they localize it to this guy. So mycobacterium is acid fast. We know they are acid fast rods. These are the way they appear. You can see that this image is also very similar to what we have for our nocardia. You guys can see it's similar a little. So
Yeah.
you can see the purple with the blue background. Yeah, so this is senescent stain. This is what it looks like. So we are still going to discuss Mycobacterium tuberculosis properly. Let's just talk about the Avium intracellulare. So Avium intracellulare is another form of Mycobacterium. It's usually very notorious in people that are immunosuppressed. So people that are immunosuppressed typically have this Avium intracellulare. I think when the CD4 count is like less than 100, that's when it comes around. So um they can cause so many infections. They can cause pulmonary infection just like tuberculosis. Similarly, like tuberculosis, no difference. The cough, the dyspnea, the chest pain, the hemoptysis, they can get worse, just like tuberculosis. In addition to causing pulmonary infection, the avium intracellulare can also cause abdominal infection. So they can cause a watery diarrhea. So you guys should pay attention to that. It's not bloody. Once you are seeing bloody diarrhea, you are thinking about another thing. There are some organisms that are known for causing bloody diarrhea or dysentery. Avium intracellulare is not one of them. It's just watery. Watery diarrhea, abdominal pain, just like affectation of the GIT. Any symptom that someone that has a GIT problem can present with. So nausea, vomiting, abdominal pain, diarrhea, and all those things can happen when it involves the GI. It can also disseminate into the blood and affect so many organs. Can go to the brain, go to the bone, go to the joint, go to the spleen, go to the lymph node. Can affect so many areas when it becomes disseminated. So disseminated form is very common in people that are immunosuppressed. So the third one is the scrofulaxium. So scrofulaxium is gotten from the name scrofula. So scrofula is when you have a cervical lymphadenopathy. So all it does is just cause cervical lymphadenitis. So someone that has a mycobacterium infection with only cervical lymphadenitis, you are thinking of mycobacterium scrofulaxium. So once you biopsy that area, you do a gram staining, you are going to see something that looks like mycobacterium. You know that this is likely to be scrofulaxium. Then the last one is marinum. So marinum is actually very common in people that handle fish in aquarium. So if you handle fish a lot and you have a wound within your hand, you can have introduction of this.
We stopped hearing you.
Hello, non-productive cough. So when you see non-productive cough, you are most likely thinking of maybe like pulmonary fibrosis because there's no inflammatory process that is ongoing currently, acute inflammatory stuff. So there's no production of sputum and all those things like pus and all those things. Do you guys get what I'm saying? Hello.
Yeah.
So for people with pulmonary fibrosis, they can have cough, but it will usually be non-productive. So if you see productive cough, you are most likely thinking of an infection. Yeah. So what are the virulence on of Mycobacterium tuberculosis? Please, can you guys still hear me because I don't trust this network? Hello,
Can.
Dr. Abisala, you can hear me? Okay. Hello.
By the way,
Ah, I think the network.
Baba.
Continue, Dr. Bramade.
Okay. Yes. So, um, so what are the virulent factor? We just need to pay attention to two of them: the cord factor and the surfactant. The the cord factor and the surfactant. So, what's the cord factor? Cord factor, cord factor, cord factor. Um, Another name for it is trialose dimycolic acid. So, cord factor is also known as serpentine cord. Just look like snake-like. So, what it does is just to activate the macrophages. So it activates the macrophages and initiate or facilitate the formation of granulomas so that you can have confinement of those tuberculous antigen or tuberculous organisms within the macrophages, within that granuloma, so that they don't get exposed to other part of the immune system and they will be destroyed. So it's just like a protective um, way for confining the tuberculosis to a particular region so that it doesn't get announced to other part of the immune system and it will eventually be damaged. So that's why they prefer to form those granulomas. And cord factor assists them in doing that. So and it also induces the release of TNF alpha. So it can assist with the granuloma formation by releasing that TNF. We are going to explain it. We are going to explain it. So the last one is the surfactant, the are sulfate glycolipids. What they do is just to inhibit phagolysosomal fusion. So once those mycobacterium tuberculosis organisms are engulfed by the phagocytes, the next thing is to fuse them with the lysosomes so that they can be destroyed. So the sulfatide inhibits that phagolysosomal fusion so that you can have persistence of those tuberculous organisms. Do you guys remember another condition that is associated with inhibition of phagolysosomal fusion, making those individuals predisposed to developing tuberculosis? Anybody?
This thing, the lack complement C5. I've
No,
forgotten.
no, 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 no. It's not. We talked about it.
Is it
Sarcoidosis.
the
Sarcoidosis.
No, no.
IgM?
It's not.
No.
It's not sarcoidosis. It's not. It's not.
Hey, we said histoplasma.
No, no, no. We said
Ah,
histoplasma.
what are you asking?
We said histoplasma and tuberculosis can cause chronic mediastinitis. That's what we said.
Okay.
So
Is it the hyper IgM something something?
no, 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 no. It is silicosis. You guys should not forget those silicosis.
Silicosis or silicosis.
So if someone has
Yes, yes,
silicosis, we want
yes,
to rule out
silicosis.
tuberculosis. They are
Yes,
interrelated. Hmm?
yes.
Silicosis, don't forget it. Those are the key points that you need to know with respect to all those pneumoconiosis. The ones that form granulomas like berylliosis can form granulomas very well. Silicosis is tuberculosis. Asbestosis is pleural plaques. Co-worker, the co one is the one that forms the um this, what do you call it now? This well circumscribed um uh masses or opacities rather. So well circumscribed opacity within the upper lobe. You are looking at co-worker most likely. And if you bring out the lungs, looking at it grossly, it will appear very black. So you need to know the salient features of each and every one of them. So silicosis inhibits phagolysomal fusion. So they are very, very predisposed to developing tuberculosis because of that. Don't forget. Okay, so the sulfatide is just like acting like silicosis too. Sulfatide, they prevent phagolysomal fusion. So let's go to the tuberculosis infection itself. So if somebody has exposure to the um, if somebody develops exposure to the Mycobacterium tuberculosis and they inhale the spores from someone that is coughing, they take it in, and it's been said or it's been discovered that the primary form of the Mycobacterium tuberculosis infection, that is the first time of exposure, the inflammatory response is actually confined to the middle lobe. So the middle lobe or the lower lobe. Some will say the lower lobe, some will say the middle lobe. Even if you have saying the middle lobe, you can say the lower part of the upper lobe or the upper part of the middle lobe. I don't know if you guys get what I'm saying. The lower part of the upper lobe or the upper part of the lower lobe.
the lower part of the upper lobe or the upper part of the lower lobe. Do you guys get what I'm saying? So it's still like you are still falling within the middle lobe. Hello, guys. Hello?
Yes, you said it affects the middle and the lower lobes, but the lower part of the middle of the upper lobe, and then the
Okay.
upper part of the middle lobe.
No, the
But I felt is that
the
contradiction?
upper part of the lower
Lower,
lobe. Upper part of the lower lobe.
yes, upper lower, then lower middle, right?
No, no. Upper part of the lower lobe. Upper part
Uh-huh.
of the lower lobe. Lower part of the upper lobe.
Eh.
Yes. So but don't if you just want to palm it, just stick.
That's about the center, sha, Abi.
Yes. So it's either Akobose center or lower lobe, but not the upper lobe. But not the upper lobe.
Yes, yes. For
So
the primary infection, right?
yes, for the primary infection, the first time. Is that it start
Mm.
at the in the middle lobe or the lower lobe? Any one of them. So when it gets to the alveoli within those lobes, the next thing is the alveolar macrophages to respond to it. So the alveolar macrophages captures it, then they present it, they drain it, they present it to the neighboring lymph nodes. So once they, because macrophages are antigen presenting cells. So once they present it to the neighboring lymph node, you sensitize the T cells there. So they release interleukin 12 so that the naive T cells that are within those lymph nodes will differentiate into TFR1. So the TFR1 cells will now what? Release gamma interferon. Gamma interferon is an activating factor for macrophages. So they will activate the macrophages more. They will recruit more macrophages. Then the macrophages will further engulf those tuberculous antigen. The T cells that are the TFR1 2 that have been activated, they will surround those macrophages too. Then the macrophages will now release TNF alpha. TNF alpha. So TNF alpha will now further convert those activated macrophages into epithelioid macrophages, epithelioid cells or Langerhans cells. That is, you have giant macrophages that are fused together to form epithelioid cells. So you have already formed a granuloma. So granuloma is already formed. In the center, you have the tuberculosis infection. Surrounding it next is the macrophages and the epithelioid cells. Then at the outermost portion is the T lymphocyte, the THR1 cell. Not THR, not cytotoxic, the THR. Those are the ones that are involved in granuloma formation. So they are trying to destroy that tuberculosis, but the tuberculosis will not get destroyed because of so many reasons. One, it has surfactide. So surfactide will prevent the phagocytes from the macrophages to fuse with the lysosome. So there's no way they can degrade them. And again, they have a very thick mycolic acid that prevents degradation. So those are the factors that help the tuberculosis survive, you know, those granuloma. But what happens to that tuberculosis actually depends on the immune system. It kind of depends on the immune system. If the person has a very weak immune system, either from an infection like HIV or from malnutrition, the tuberculosis will continue to proliferate within that granuloma. They will continue to proliferate. They will continue to proliferate. And at the end of the day, they will burst out from those granuloma. They are going to destroy the granuloma because they will overpower the macrophages and the T cells. They cannot contain them. So they will overpower them and they will lead to what we call progressive lung disease. Now, when they say the lung disease is progressive, they don't mean that the damage that they cause in the lung is more. No, it's just that the tuberculosis, the granulomas, the tuberculous organism within the granulomas are proliferating more than what the granuloma can handle. At the end of the day, they will break off those granuloma and they will find their way into the blood, causing bacteremia. So when it gets to the blood, it can disseminate to so many regions. It can go to the brain, causing meningitis, tuberculous meningitis. It can go to the vertebrae, causing port disease. They can go to the spleen. They can go to the adrenal glands. They can go to the joint, the lung bones. They can go to the liver, the lymph nodes. So many areas disseminated from. And at that time, they can also go back to the lungs. In that form, you are going to be seeing millet appearance on X-ray, like a kind of diffuse affectation of the lung. So that's what we call the miliary TB. That's one of the complications of bacteremia from primary progressive primary tuberculosis. So that one actually happens in 10% of people. In 10% of people, in 10% of situation rather, not 10% of people, in 10% of situation when you have infection from tuberculosis. In 90%, in 90%, the tuberculosis, the tuberculous organism within the granuloma will just be dormant. So they will just calm down within those granuloma. They will not proliferate again. At the end of the day, that those granuloma they are going to heal by fibrosis. Now, there's something we call the gum focus and the gum complex. Now, you guys remember that we said that okay, when the bacteria comes in initially, they have been taken to the middle or the lower lobe of the lungs where you form the granuloma. But you remember that the lungs are being drained by the lymph nodes. So all those antigens are also being transmitted through the venous blood to the lymph node. So when they are, through the lymphatics rather to the lymph node. So when they get to the lymph node, the granuloma reaction also occurs in those lymph nodes, particularly the hilar lymph nodes. Now, at the end of the day, the granuloma, the organism within those granuloma will become dormant, and the granuloma will heal by fibrosis. So when you have fibrosis of those hilar granuloma and fibrosis of the granuloma within the lower lobe or the middle lobe of the lungs, you call them the gum complex. So the addition of your fibrotic granuloma in the lymph node and in the lung parenchyma is what we call the gum complex. The isolated one, that is the one only affecting the lung parenchyma, is called gum focus. Do you guys get what I just said now? So gum focus is when you have fibrosis of the granuloma within the lung parenchyma only. So it now becomes gum complex when there is fibrosis of the hilar granuloma too. So you call that the gum complex. Do we get it? Hello?
Yes, please. Yes,
So
please.
those granuloma
Yes.
in the lower lobes, the gum focus, the granuloma in the hilar lymph node are then together with the one in the lobes, we call them the gum complex. Now, just like we said, it can get fibrosed and it can get calcified. So we have dystrophic calcification of those granuloma. So, we have two types of calcification. By the time we are doing pathology, we are going to talk about them. So the one that follows diseases, dystrophic. The one that there's no disease. It's just that calcium is just too much in the body. That's why we call it metastatic, calcification. Calcium is just too much. That's why it's depositing in different tissues. Not because there's disease in those areas. But in people that have diseases, healing by fibrosis, you can have calcification of those areas. And that kind of calcification is a dystrophic calcification. So it happens in people with, this primary tuberculosis that is healing by fibrosis. So they can get calcified. Once they get calcified, we call the gum complex Radke complex now. So the name now changes from gum complex to Radke complex. You guys don't need to know all those things. It's not something that will be tested, but just
So there's the difference between case complex and gun complex.
yes. So when you have
Eh?
calcification of those complexes. So when you have granuloma initially, those are the gum focus and the gum complexes. Now, when they now heal by fibrosis and calcification, when they now get calcified, you call them the Radke complex. Do you understand? So when there is now calcification, they become the Radke complex. So that is it. Do you get it now, Dr. Latobi? Dr. Latobi? Hello? Hello?
Dr. Babali, thank you.
I can barely hear you. Is it my network now or what?
Mr. Can you hear me?
Okay, I think I can hear you now. So when there is calcification now, Radke complex. Now,
I said calcification of Okay. Okay.
Yes, yes.
Thanks.
Okay. Um, please, if you guys cannot hear me, just let me know because I don't trust this network. It's kind of very bad today. So now, when they now get healed by fibrosis and they are calcified, so what can happen to them? So the next thing that can happen to them is reactivation. They can get reactivated. So the reactivation can happen in two forms. Is either there is reinfection or there is reactivation. Sorry, what I meant is secondary tuberculosis. So all these things we are initially looking at is primary tuberculosis. The first infection. The first infection. What are the two fates of the first infection? It can progress to a primary progressive disease that eventually becomes bacteremic and can disseminate to other organs, or it can be confined. It can become latent and not cause any bacteremia. Now, that latent one, it can now get activated again. So either by you introducing another new infection or the one that is already there fires again, becomes reactivated. So both of them will eventually cause secondary tuberculosis. So this one is not actually the first time. This is the second time. The second time of the infection. Is either you are introducing another organism, or you are reactivating the one that was initially dormant. Now, when this one comes around, the inflammatory response now affects the upper lobe. This one is more destructive. That's the word. Because of the fact that for reactivation to happen, most likely the person must be immunosuppressed or be malnourished or be using some form of immunosuppressives or have some form of infection that's affecting the immune system. Please, are you guys with me? Hello?
Yes.
All right. So the infection will migrate to the upper lobe of the lung where it has the highest oxygen, where it can get the highest oxygen. So that is where the inflammatory response is going to be. But you guys remember that for this to even happen, for them to have the reactivation of the previously dormant infection, it means that the immune system that is forming those granulomas have become weak. So that means that your macrophages, they will just be limited in supply. Your T lymphocyte, they will just be very limited. So they'll form the granulomas too, but they'll be very, very minimal and they'll be very weak because they cannot contain that tuberculosis. The tuberculosis will proliferate very severely and cause damage because tuberculosis can release some necrotic factors, some necrotic toxin that can damage the lung parenchyma. So those toxins destroy the parenchyma of the lungs, causing necrosis of those lung tissue. And at the same time, those necrosis will now coalesce together to form cavities. So you see cavities, and there will still be some form of healing around those cavities. So we call them fibroschious cavitary lesion. So fibroschious cavitary lesion, that is um, cavities within the lung parenchyma that is contained the granuloma, which has a central necrosis with surrounding area of fibrosis. And it typically occurs in the upper lobe of the lungs. So you have the granulomas that are forming with a caseous necrosis, but the bacterium within those granuloma, which is forming the caseous necrosis, is actively proliferating and destroying the lung parenchyma, forming necrotic areas, which coalesce together to form cavities. Those necrotic areas tries to also heal by fibrosis. So you are going to have surrounding area of fibrosis within the cavities, and within the cavities, what you are going to have is the caseous necrosis. It's the caseous necrosis that's forming the cavity. Groups of caseous necrosis forms cavity. Those cavities, some areas of the cavities are also healing by fibrosis, leading to fibrocaseous cavitary lesion. So once you see that, that is likely to be a secondary tuberculosis. You don't form cavities in primary tuberculosis. There are no cavities in primary tuberculosis. You can only see the granuloma, the caseous necrosis without cavity. Once you are seeing a cavity, that is secondary, that is most likely a secondary tuberculosis. Most likely due to reactivation, maybe from immunosuppression or malnutrition or anything. In some situation, maybe like in 20 to 10%, it is due to the fact that you are getting infected the second time by tuberculosis again. So that now causes a local, destruction of the lungs. Do you understand the way tuberculosis can present now?
Yeah.
Okay. So we know the clinchers for secondary tuberculosis. We know what to look out for. Yeah. So that is that. So what are the tests, the screening tests that we do? The PPD, that's a purified protein derivative. We talked about it. So it's usually positive in people with current infection or past exposure. So someone that has a current infection or a past exposure, both of them have been exposed to the tuberculosis antigen. They have mounted an immune response to that antigen. They have produced T lymphocytes to those antigens. You remember that macrophages and T lymphocytes will be activated. It is a type 4 hypersensitivity reaction. So the memory T cells are already in the plasma. So the basis of the PPD is that now introduce a an attenuated form of those tuberculosis antigens, that is the one that is least capable of causing infection. So it doesn't cause damage to the lung. It doesn't cause serious infection. It has been kind of subdued. Now you now introduce it into the person. The T memory cells, they are going to respond to those antigens, and they are going to form a reaction. So those reactions are going to appear like a form of erythema, a circular erythema within the skin. So you can measure the diameter and say that it is positive or negative. So you should not worry about that. The basis for the measuring differs. It depends on the background of the person. If the person has HIV, the reaction might not be very, very rigorous, because in HIV there's immunosuppression already. So someone can have HIV and have tuberculosis. You won't expect the kind of reaction that kind of person to be similar to the reaction you get in someone that has tuberculosis and has a normal immune um, response. In someone that has a normal immune response, the response to that PPD will be more aggressive. So the inflammatory zone will be wider than someone that has HIV. Please, I don't know if what I'm saying makes sense to you guys. Hello?
Yeah, I make
So the cutoff for someone that has HIV is like 5 mm or so. It's like 5 mm. While someone that has LD immune system, I think is about 15 mm, but we should not worry ourselves about that. So PPD is not specific. It can be positive both in someone that has a current infection or past exposure, because both of them have been exposed to those tuberculosis antigen before. Now, PPD can be negative in some condition. Now, it can be falsely positive in some condition. What are these conditions? Someone that has BCG vaccination. You guys know that it will be positive in someone that has taken BCG, right? It doesn't mean that the person has tuberculosis, but the person has been
yes,
exposed
it
to the tuberculosis antigen. So the person will be falsely
has
positive.
been explained.
Yeah. So somebody that has Mycobacterium leprae infection, leprosy, because it's a mycobacterium too, PPD2 will be positive in that person, and it's not tuberculosis. Yeah. So there are some false negative situations too. The person has tuberculosis truly, but the PPD test is negative. How can that happen? Someone that is immunocompromised, someone that is malnourished. So you know that the basis of that is immune response, like
Probably does stature also determine a
stat
person's stature?
stature. Ah, I'm not sure. I don't think there's a link. Can you link it to immunity? Everything has to be linked to immunity.
Oh, okay, so it will still be immunity at the end of the day. Okay, okay, okay.
Yeah. So
Oh, because
if
I remember, so there was a time I read somewhere, I can't remember now, that um, lean people, HIV, very sick people, elderly people, malnourished people, like they have a lower cutoff or so. I'm not sure. Let me not say what I'm not sure. Maybe
yeah,
it's still the malnourishment thing.
so minorities, those ones can be, proven. People that are immunosuppressed, people that are malnourished, because they cannot mount adequate immune response to that antigen you are injecting. So you have little inflammatory response to see within the skin, because you have to inject the antigen subdermally into the dermis, so that you can appreciate those inflammatory response form of erythema. So people that cannot mount the immune response very well, it will appear falsely negative in them. Like someone that has a low CD4 count, maybe from HIV. It is the CD4 that is responding to the antigen. Do you guys get that? So anything that can make CD4 count go down will cause a false negative
Yeah.
reaction. So the next one is this interferon gamma release assay. So we use this interferon gamma release assay to make diagnosis of latent tuberculosis. So you want to know that, okay, does this guy even have a latent form of this tuberculosis? Now, the basis of that is that you guys remember when we were talking about the formation of the granuloma, we said that it is the CD4 cells, the TFR1, that will release interferon gamma that will activate macrophages, right? We said it's a macrophage activator, interferon gamma, so that the activated macrophage can now release TNF, so that the TNF can now make the activated macrophages differentiate into the epithelial macrophages because they are fused together so that they can form the granuloma. Can you guys connect what I've said?
Yes.
Okay. So what you now do to test for the interferon gamma release assay is that you introduce tuberculous antigen to them. You will now assay for this interferon gamma. So that means that someone that has a latent infection, the T cells are already there. So once you introduce the antigen, they are going to respond to it and they are going to release interferon gamma so that they can activate macrophages to engulf those antigen. So interferon gamma will be elevated in them. But it has some false positive, causes too, like someone that has BCG. In someone that have taken BCG, you have already produced immune cells, like your memory T cells too. So if you give them the tuberculous antigen too, they will react to it and they will release interferon. It doesn't mean that that person has tuberculosis. It's just the same like this PPD. It's just that what you are measuring differs. You are measuring the diameter of your erythema in PPD. You are measuring the release of interferon in IgRA. Do you guys get that?
No, the interferon assay, I don't get it. Sorry.
Okay. You know that we've said it that um, if you want to form the granuloma in response to the tuberculous antigen, you are going to activate the T cells first, right? So once the T cells
Yes.
become activated,
The
they will release,
CD4, the CD4 T cells,
yes, the
the upper
CD4
one.
cells or the TFR1, yeah. So they will release interferon gamma. So we said interferon gamma is a macrophage activator, right?
Activator,
Yes.
yes,
They will
yes.
activate the macrophages. Now, once the macrophages become activated, what will they do? They will secrete TNF. Now, TNF from those activated macrophages will now cause those activated
So,
macrophages.
so Dr. Babaka's question.
Hello? I'm listening.
Dr. Babali,
Mhm.
so interferon gamma is from the T helper cells.
Okay.
TNF TNF is from the macrophages, right?
Yes, that's correct. That's correct. So,
Okay.
so the purpose of that is to form granuloma. You get, that's why you can have your macrophages, your TFR cells, your epithelial cells, so that they can
Yeah.
surround the tuberculosis antigen and they can form granuloma.
Yes.
Now,
Yes.
we are now saying that if somebody has a latent infection, you know that that person will have produced TFR cells in their serum. It will have been there. You know
Yes.
that. Now, sorry guys, 1 minute. The T cells will respond to those antigen. Abi now, Dr. Luatobi, those memory T cells will respond to the antigen that we are introducing. Abi, hello, hello. Ah, hey,
I just started hearing you now, Dr. Babawadi.
hello. What did you say?
I just started hearing you now.
Okay,
I don't know if others could hear you, but I just started.
okay. So I said that the interferon gamma. So you want to confirm a latent infection. You know that in someone that has a latent infection, they have been previously exposed to the antigen, to the tuberculosis. Abi, hello.
Yes, that's correct.
So that means that they already have the T cells in their plasma. The T cells that are responded to that to those antigen then is already in their plasma. So if you now give them a new tuberculosis antigen, they will respond to those antigen The T cells are already there to respond to the antigen. So they want to contain the antigen and form granuloma. So once the T cells see those antigen, what will be the next thing that they will do? They will release interferon gamma, abi, so that they can form, so
Yes.
that they can activate macrophages.
They can activate the
Exactly.
macrophages. Yes.
So it means that someone that has a latent infection, most likely you are going to see elevated interferon once you introduce a new tuberculosis antigen to them. Abi, that one is clear. Hello?
Yes.
Now, we are now saying that there are some conditions that can cause a false positive. Example, someone that has a BCG vaccination. You know that someone that has a BCG vaccination, you have already introduced the tuberculosis antigen to those persons too, but it is just the inactivated form. So that those ones
Yeah.
will have mounted immune
Yeah.
response and they will have produced T cells too. So if you introduce another T cell, another tuberculosis antigen to them, those T cells that have been formed will respond to those antigens too, and they will release interferon. Do you understand? So you cannot
Do understand? I do now.
yeah. So
Yeah.
that's what it is. All
So
right.
there is really no way, or if it's just
Hello. Hello.
BCG.
Hello,
Can you hear me?
Dr. Olato, what did you say?
Can you
Hello?
hear me? I said you can differentiate some TB with interferon assay.
Yeah, so you cannot differentiate them with interferon assay. Hmm? Hello? 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 Hello?
Hey, Dr. Babadi.
Yeah, so I said we cannot differentiate them with the interferon assay. So so that is that. So the gold standard to make diagnosis of TB is actually the culture. So you have to do the lowest in Jensen culture and you grow it. That's how you can say that this guy has tuberculosis. So they said we should not confuse the Langerhans cells with the Langerhans. The Langerhans cells with the Langerhans. So the Langerhans, the one that has ER, those are the dermal antigen presenting cells. The Langerhans cells are the epithelial cells. Those are the fused macrophages. So you guys remember the way we said that we are going to form these few macrophages. How did we say we are going to form these few macrophages? This fused one. Hello? Hello? Yeah. So how did we say we are going to form these fused giant cells? These fused macrophages that form the Langerhans giant cells. How did we say we are going to form them? Is it that you guys don't remember or you cannot hear me? Please let me know so that I can say the answer and move.
Hear you, but I'm trying to remember how they form.
Okay, so I said that those are what is going to happen once we
The
have the macrophages releasing TNF. So once the macrophages release TNF, they are going to make they are going to fuse together and form epithelial cells, which are also known as giant
the
cells.
again.
Hello?
I'm just hearing you now.
Sorry, I don't know what is wrong with this.
But and the TNF alpha.
Yeah. So what about now? What about now? Hello? Hello?
I can hear you now.
Okay. So I said that um you form those giant cells once the macrophages release TNF alpha. So they are going to act on themselves so that they can join together, they can fuse together to form epithelial cells. Those epithelial cells are also known as the giant
Yeah.
cells. They're also known as the germ cells. And I want you guys to know the differences. There's Langerhans, the one that has ER, and the Langerhans. The Langerhans are the germ cells. The Langerhans are the dermal antigen presenting cells. Can we see that? Hello?
Yes.
Okay. All right. So TB reactivate.
Shorter one TB. Shorter one TB. Langan TB. Langerhans is the demis.
Is
Yes.
them is here. So people that can have TB reactivation are people that have HIV, people that received organ transplant, people that use TNF alpha inhibitor. We've talked about this TNF alpha inhibitor of a thing. Before you can give somebody infliximab or anything that suppresses TNF alpha, etanercept, and all those things, you have to rule out tuberculosis because you know that the TNF alpha is responsible for forming those Langerhans germ cells, the Langerhans germ cells, that can help to form the granuloma. You guys remember? So if you give somebody the TNF alpha inhibitor, it will break down the granuloma and you have a disseminated tuberculosis. Or a tuberculosis that can reactivate because it now starts proliferating. There's no granuloma to contain it again. Do you guys get that? Hello?
Yes.
Maybe we should just stop this class because I'm not sure you guys
Probably,
can hear
yeah.
me.
The network is really disturbing.
Yeah.
Sorry.
So let's just stop it. Let's just stop it. We'll just continue from here the next time. It's very difficult to fully
All
handle.
right.
Okay.
Yeah.
But you
Thank you
guys, you
very
guys, you guys get what we have explained so far,
much.
Sha? You guys get what we have
Well,
explained so far. Okay. All right.
Sure. Listeria. Listeria will cause